this was a case I was part of managing the team, so I was not a principal consultant. I have observed this case during my residence days, but I thought this is an interesting case, so I had to discuss with you. So, 22-year female admitted with fever since 8 days, rashes all over cold since 4 days. Initially, she was admitted at one hospital. During that hospital, she developed difficulty breathing, hematuria, hemoptysis, and bleeding from gums since last 2 days. On evaluation on the first hospital, she had thrombocytopenia, leukopenia, and IgM positive. USG suggestive of mild ascites. So, on the very first hospital, she was managed with the oxygen, IV fluid, and blood product as per requirement. Then from that hospital, she was referred to some second hospital, which was upgrade to that one hospital. So due to increased oxygen requirements, she was started on non-invasive support. Chest X-ray was suggestive of multiple bilateral opacities and in lower zones. EBG was suggestive of severe hypoxemia. And after 8th day of illness, still patient was on NIV and she was continuing deteriorating, so she was shifted to our hospital for further management. So on arrival to our hospital, she was conscious but had tachycardia, tachypnea, hypotension, and severe respiratory distress. She came in a late night around 11 p.m. or between 11 p.m. and 12 a.m. I was on duty at that time. Bilateral cavitations were present to auscultation. She has fatigue on all the extremities. Due to hemodynamic instability and respiratory distress, he was intubated and kept on mechanical ventilation. Vasopressor support was also started with intravenous fluid. She was managed with IV fluid, crystalloids, antibiotics. As the patient was admitted for 8 days at other hospitals, so we have considered this sepsis also one possibility. So we have started antibiotic and lung protective ventilation was started with PRVC mode. This was last X-ray outside the X-ray before admitting to another hospital. And this was after intubation we have taken X-ray in our hospital. It was suggestive bilateral multiple opacities. Differential diagnosis was related ARDS, and patient has anemia around hemoglobin was between 6 to 7. So patient has history of hemoptysis to our second. DD was also bronchoalveolar hemorrhage secondary to thrombocytopenia and AU. So on arrival, she had severe thrombocytopenia. The platelet was 12,000. Leukocytosis, WBC was 20,000. LDH was high. CRP was elevated. Elevated liver enzyme in form of 228 SGOT and 116 of SGPT, and ferritin was 89.33. Liver surprisingly renal function was
bleeding profile. Bleeding profile.
Blood PT was 20. 20. 20. PT was 20.
खबर ना हो तो it's fine
ना ना चाहिए शॉर्ट में बनाया था कार्टून माटे प्रेजेंट करवा माटे એટલે બધું ડિટેલ માં
FTP D-dimer.
FTP D-dimer was normal.
They were normal.
Yes. It was normal throughout the case because we have done FTP D-dimer 2 times.
Highly unusual.
Highly unusual.
It is not possible rather કારણ કે તમારું પેશન્ટ આટલા સ્કોપમાં ગયું હોય ને અને બ્લીડિંગ પ્રોફાઇલ ઓલમોસ્ટ નોર્મલ હોય ને આટલા બધા બ્લીડિંગ હોય this is unheard of.
So echo was also done to rule out myocarditis. It was normal. Test for malaria was also done, which was normal. Leptospira was sent. Scrub typhus was also sent. The induced serologic IgM by ELISA was positive. CCHF NIV Pune was also ruled out because
echo માં ખાલી myocarditis જ આવી શકે આમાં બીજું ના આવી શકે. What is acute PE? Acute PE can also be there.
Acute PE can also present with this. Acute PE with bilateral obesities.
Several require systemic role થઈ જાય પછી બધું સ્ટેજ.
These are very unusual presentations, but echo was normal. So after intubation, gradually her hemodynamic status was improved. Vasopressor was stopped on 5th day. Oxygen requirement was also decreased. On day 13th of admission, she was extubated after successful XPD. patient platelets were transfused daily. We have transfused 1 STP to keep the platelets above 20,000. During the whole hospitalization course, patient received 15 STP and 8 PRCs. So we have extubated the patient. After extubation, patient was on room air. Patient was shifted to ward. There was no bleeding from any side, and still patient has a persistent thrombocytopenia. It was only concern to relative also that why platelets are not improving, and concern to us also that why platelet was not improving. Persistent thrombocytopenia was the concern in this patient. So patient was admitted 8 days before our hospital and 13th day of so at almost 21 day of illness, still patient has a persistent thrombocytopenia. And platelets were never touched more than 20,000 during the whole 13th day of hospitalization in our hospital. So we have cultures negative. Bajaj negative. Procalcitonin was also negative of initial the first meeting.
So up till now it was pure viral.
Yes, it is pure viral. So persistent thrombocytopenia. So I was reading for cases, many cases for like this. So we have again sent ferritin of this patient. It was also normal. So HLH was also. So last case was our HLH, in which also there is persistent.
What was the liver and spleen?
Liver mild hepatomegaly was there, more than 2 centimeters. Spleen was normal.
Spleen was
Normal. On repeat USG also, it was normal. So we have, I have seen.
HB get to
Hemoglobin on presentation was 7. We have said vitamin B12 also, it was more than 2,000 because it is very common practice to give either in each and every admitted patient. All hemolytic, after non-responding thrombocytopenia, we have also done all hemolytic profile G6PD and peripheral smear पण જોઈ. Peripheral smear would also not suggestive of any microangiopathic hemolytic anemia. Viral markers were also sent, which was also
kidney
function surprisingly didn't worsen during the whole hospitalization. So patient now in ward, no complaint, no bleeding from any side.
Pure cases तो foreign में मरे, भारत में तो बड़ा मुश्किल.
No bleeding from any side, and it was surprising to us also, but platelets was not improving. So now their HLH is also very common. So we have again sent to the ferritin. Repeat ferritin was also negative. ANF profile was also sent, which was negative. Hepatitis B, hepatitis C was sent, it was also negative. HIV is very common cause of persistent thrombocytopenia, it was also negative. PT-ABDP fibrinogen bilirubin was also sent, it was negative. And there was we have tried to rule out all the possible causes of thrombocytopenia in this case. Like it can be a DIC, it can be a microangiopathic hemolytic anemia, or it can be secondary to HLH, or it can be a sepsis. But we have again sent blood culture, which was also negative. PCT was also done second time, it was also negative. Then so usually, rather than managing single-handedly this type of case, we usually ask for call for help. So my answer to this question was, what will you do? So this will say that we will ask for call for help. So we will do send ferritin and start pulse dose of syrup and do a call for help. Call for help is any form of specialized person in that field that will guide us to what to do in this type of cases. So we have also consulted hematologist. Bone marrow biopsy was also done. It was suggestive of normal cellular marrow with increased megakaryopoiesis. So IV methyl prednisolone 500 mg for 3 days was also given, which also doesn't show any significant improvement in platelet. And so IV MPS was also given, which also doesn't increase the platelet up to the level. Then we stopped the transfusing platelet. case. And there was a 2005 WHO has published one paper. In WHO there is a dengue and ITP, dengue and immune thrombocytopenia purpura. So it was published in WHO 2005. Then it was again published in RMS 2015. Then 2018 in Sri Lanka, 2019 in Malaysia, and India 2021 pediatric. So this type of phenomenon usually happens in pediatric groups. HLH also usually happens in pediatric groups. And now all those things are extrapolated to adult group of persons. So no, as there was no.
Usually, when it comes to immune thrombocytopenia, post-viral immune thrombocytopenia, the virus as a cause of ITP is a known case.
Known case.
We don't know if dengue can cause.
Yes.
If you consider dengue as a virus, eye viral infection, or for that matter, any say, when ITP occurs 2 or 3 days back, patient develops some upper respiratory viral
infection,
and then subsequently
some infection.
So usually it is known. Post-viral ITP phase.
Ipting virus, cytomegalovirus, and HIV, hepatitis B, all are regular, and there are multiple case reports for this. But as a particular dengue, there was no any particular case known to us. So IVIG was given as a dose of 0.4 gram per kg per day for 5 days, and after IVIG admission, we have a dramatic response. And on day 24 of admission, he was discharged with 1,58,000 platelet. In follow-up also, after 15 days and 1 month, her platelet was stabilized.
Here there are 10 or 20,000 count resolution. Was the patient followed with bleeding time?
No, there was no bleeding. Only
Are you talking about bleeding time investigation?
No, we have not.
If the bleeding time is not prolonged, that means in case of splenomegaly,
Yes.
patient is in hypersplenism and thrombocytopenia.
Yes.
They do survive with low platelet count because the bone marrow response is good. If the bone marrow response is good, there is no need to chase that thrombocytopenia because the patient is not symptomatic for that thrombocytopenia. It is your concern the count is low.
Yes.
But the patient do not have bleeding tendency because the bone marrow response is very good.
So,
What was the immature platelet fraction in this?
so we were not doing immature platelet fraction at that time, so we have not done immature platelet fraction.
This is classical ITP, that's it.
We were not doing that at that time. IPF putting in, so we have not sent. Bundelo we have done, but we have not sent IPF.
Yeah, but જો IPF તમારું સારા લેવલ પર હોત તો બોન મેરોની જરૂરિયાત જ નથી.
And it is also in ITP guideline also there is no need to do a bone marrow to stem ITP.
Exactly.
Everywhere it is written that there is no need to do a bone marrow to label as ITP.
ITP ની અંદર પણ usually unless there is a bleeding you should not give platelets. That is the issue.
So less than 30,000 count and there is no bleeding, there is no need to transfer.
30 કરતા હવે તો 20 પર આવી
I have seen dengue patients, I have treated 3 patients since 2003. Dengue fever epidemic over there. I have treated 3 patients of 2,000 platelet count. Just wait and watch policy.
nothing else.
Nothing happened because the bone marrow response is good. Maybe minor bleeding in the sense of
Sometimes some
category in the both the lower.
That is possible even with 1 lakh platelet.
that is possible with 1 lakh. So platelet is
It
usually
because
doesn't
of the
clear
platelet.
dengue patient. Low platelet doesn't clear dengue patient by and large.
See, when it comes to dengue, your concern is intracellular hemorrhage. And what is the incidence of intracellular hemorrhage? 0.3%. 0.3 means 1,000. If 1,000 patients is in less than 10,000 count, the incidence of intracellular hemorrhage is 3 out of 0.3%. So, in most of the cases, wait and watch policy, and as you see, most of the time you get it done IPF fraction.
Yes.
If it is very good, that means bone marrow response is very good.
So that I have mentioned these 5 cases. Out of these 5 cases, 4 patients were discharged with low platelets from hospital. out of 5 patients, 4 patients were discharged from the hospital, and within 1 month, all these 5 patients, all these 4 patients presented with some of the bleeding episodes in form of epistaxis or a mucosal bleeding, and then they have again repeated the all blood hemograms, and they again find that this is a persistent thrombocytopenia, and then they have treated as a ITP in this case all these 5 patients. Initially, they have also discharged all these 5 patients.
See you. તમારું પેશન્ટ જ્યારે તમારી પહેલાની હોસ્પિટલમાં આવ્યું હતું ત્યારે there were bleeding, right?
Yes, there were bleeding.
તમારે તો પ્લેટલેટ આપવાના જ હતા, right? But what is opposing factor here is કે આટલું સિવિયર વર્સનિંગ થયું હોય અને તમારું પેશન્ટ ડેન્ગ્યુ શોક સિન્ડ્રોમમાં છે એવું તમે કહો અને બ્લીડિંગ પ્રોફાઇલ નોર્મલ રહી જાય, this is not possible.
It is very unheard of. And initially, it was not like a completely shock like of patient. Once we have started resuscitating in our hospital after intubation, the blood pressure and pulse pressure were tried pick up immediately. So initially we have
કયા બ્લીડિંગ હતા શરૂઆતમાં?
હિમોપ્ટિસિસ ગમમાંથી બ્લીડિંગ હતું અને માઇલ્ડ હિમેચ્યુરિયા કેથેટર ને એવું નાખી દો.
Have you ruled out vasculitis?
હા ના એ અંકા સી અંકા બી અંકા નતું કાઢ્યું પણ એને પ્રોફાઇલ was negative.
Vasculitis in 25-year female with hemoptysis na to, but yeah, it has to be ruled out.
And this was also possibly a bronchoalveolar hemorrhage also. Otherwise, this type of ARDS of dengue usually doesn't get extubated. It was maybe a bronchoalveolar hemorrhage and that got recovered so fast.
So it was almost sort of patient was going into the most dreaded complication, but કદાચ તમે ટાઈમે ઇન્ટરવ્યુ કરી દીધો એટલે બ્લીડિંગ પ્રોફાઇલ વર્સન ના થાય. Otherwise it could have. ડેન્ગ્યુ વેક્સિન આવી ખબર પડી.
Like the about the patient must considering the excessive cytokine response. જે રીતે કોવિડમાં interleukin 6 ને કરાવતા હતા, that should be done. That is what I think. અને જો એ વધારે હોય ને તો પેલો શું આપણે ટોપો કયો આપે છે?
Tofacitinib છે, tocilizumab છે.
So that can be tried. Because this is ultimately it's a multi-organ involvement. Multi-organ involvement occurs due to some kind of cytokine response, excessive cytokine response.
So dengue is this was the 2009 guideline of WHO. So in our Indian population there was still a classification of dengue fever, dengue hemorrhagic fever, dengue shock syndrome. But WHO has removed it from 2009. There is a dengue fever with warning signs and severe dengue. So, and there are 3 phases of febrile phase, critical phase and recovery phase. All the complication or plasma leakage or heart space lossing will going to happen in a critical phase. Critical phase is characterized by plasma leakage, vascular permeability leads to rise in the hematocrit is the earliest sign. Moderate to severe thrombocytopenia can occur. Careful monitoring of the warning sign is very much recommended in the critical phase. So they are focusing more and more on the warning signs. So what are the warning signs as per our newer guideline of India, which was released just last year, 2023. So warning sign is persistent vomiting in dengue patient, persistent abdominal pain and tenderness, patient become lethargic or patient become restless, bleeding manifestation like epistaxis, melena or hematomesis, hematuria, history of syncopal attack or a giddiness, clinical fluid accumulation, ascites or a pleural effusion, hepatomegaly more than 2 cm, progressive increase in hematocrit and with rapid decline in platelet. These are all the warning signs. If patient is dengue with fever with warning sign, we need to admit it, and when this warning sign appears, we need to chase it as soon as possible.
So બધામાં છે ને બધી લક્ષણ રેખા બહુ પાતળી હોય in a given patient. Even today you consider કે આ ફેબ્રાઇલ સ્ટેજમાં છે અને સાંજે ક્રિટિકલ ફેઝમાં છે. very
febrile phase and critical phase usually
લક્ષણ રેખા બહુ પાતળી છે.
very difficult to
જેના કે સવારે પેશન્ટને તમે જોયો ને સાંજે આવે કે સાહેબ બધે ચક્કર આવીને પડી છે ને સિંક બી થઈ ગઈ ને.
This is also good table was given in new dengue guideline in compensated shock and decompensated shock.
MOHF ની activation એની અંદર ક્લિયર કટ.
So this is also new guideline 2023. They have also given this good recovery phase usually in the last 2 to 3 days. The severe dengue they have defined as any patient having a shock or
recovery phase में है ना, I will most of we have seen by the time we discharge, and SDPT 300-400, 7 to 8 days. Again it rises. And it takes 1 month. You know, ये SDPT ने normal दादा 1 महीना लगे. तो आपने कहा कि recovery phase 3 to 4 days है, but जो liver enzyme days था ना, तो it lasts for 1 month.
So dengue हैरान करे वो dengue में liver enzyme એટલે acute liver failure જે થાય છે, that is very difficult to manage. If it happens, it is very less chances of survival. So
that you are talking about pulmonary
Pulmonary
બાકી સાઈડ જે છે જે SGPT SGOT રેસ થાય એ એસિમ્પ્ટોમેટિક હોય છે મોટે ભાગે અને પછી 2 થી 4 અઠવાડિયામાં પાછા નોર્મલ થઈ જાય.
So, regular monitoring of PT or INR.
guideline આખી છે 2000
Regular monitoring of INR is very
તમે કહો ને કે ફેબ્રુઆરી phase નું, I had a young lady 40 years. Day 1 dengue positive. Day 2 SGPT increased by 500. Third day morning મને મારા સ્ટાફનો બોલાય સાહેબ આમ તો બીપી રેકોર્ડ કર્યો. Third day I am talking about. એટલે immediately I shifted her to the dental center તે બાદ. અને જો તો બધું PT PTT બધું right. We gave 6 trace proton plasma SDP by the evening. Now by the evening she succumbed to death. This is third day.
થર્ડ ડે ઓફ તમારું એડમિશન કે થર્ડ ડે
ના third day of illness.
So,
થર્ડ ફીવર ઓનસેટ ના ત્રીજા દિવસમાં
Fever onset થી ત્રીજો જ દિવસ.
then it may not be dengue.
This newer guideline also they have very well explained the pattern.
My point is
એ લોકો એવું કહે છે કે
ultimately
સેકન્ડરી ડેન્ગ્યુની અંદર આવી રીતનું પ્રેઝન્ટેશન ખાલી થઈ શકે સેકન્ડરી ડેન્ગ્યુ.
And they have explained that there is a direct injury from the virus and second mechanism is direct secondary injury from the antibodies and complements. So direct injury to the virus to the endothelium and this also causes vasculopathy, coagulopathy and organ dysfunction.
પણ એમાં ઇન્ડેક્સ ઇન્ફેક્શન વિધિન 4 to 6 મંથ હોય તો જ થાય. ઓકે શોર્ટ ટાઈમમાં બે ઇન્ફેક્શન થાય તો 2-3 વર્ષ પહેલા થયું એવું તો ના થાય.
And this is also
all previous
this is also high risk factor for the severe disease. So obesity